All right, welcome everyone to today's RSNA SIG webinar. We are doing a first of its kind mini lecture series diving into immersive reality. But first, a few housekeeping items that we want to bring up. Number one, who are we? So RSNA SIG is within our parent, RSNA, Radiological Society of North America, which has a mission of promoting excellence in patient care and healthcare delivery through education, research, and technologic innovation. And specifically within the 3D Special Interest Group, or 3D SIG, our mission is to promote quality, safety, and innovation in 3D printing and immersive imaging as applied to medicine through education and research. SIG recognizes the primary role of radiology and the fundamental importance of interdisciplinary collaboration in this expanding area of practice and investigation. And we would love for you to join us and become a member if you haven't yet. There is a website here and also a QR code that you can snap. Today, we're going to be doing 3 mini talks, and we're going to cover 3 different aspects of immersive reality, which encompasses virtual reality, augmented reality, and other forms of 3D advanced visualization. We're going to hear from Dr. Justin Ryan talking about enabling accessible 3D for clinicians. We're going to hear from Dr. JP on virtual reality and understanding complex pediatric congenital cardiac defects anatomy for pre-procedural planning. And we're going to hear from Mr. Scott Hendrickson and Mr. Fred McCabe from the VA talking about IT implementation of augmented reality and virtual reality at the Veterans Administration. And what this is going to allow us to do is dive into 3 different aspects. First, thinking broadly, what are some of the major tools that could be used for imaging? A deep dive into complex pediatric congenital cardiac disorders, and then kind of zooming back out in the nuts and bolts of how do you get it done. 3 amazing speakers here. Just want to highlight a few things here. Dr. Justin Ryan is a research scientist at Rady Children's Hospital, San Diego, and is the director of the Helen and Will Webster Foundation 3D Innovations Lab. This lab creates patient-specific anatomical models for surgical and procedural planning, in addition to research regarding anatomic and morphological variation. Dr. JP is the manager of the 3D Printing and Innovation Lab, the Department of Radiology at Nationwide Children's Hospital in Columbus, Ohio. This lab provides support across the enterprise to all the specialties of physicians and researchers for extended visualization and pre-surgical planning and simulation since 2017. Dr. JP is a trained dental and maxillofacial surgeon who has worked in medical applications of 3D printing for over 20 years. And finally, we have Mr. Scott Hendrickson and Mr. Frederick McCabe, who are both advanced IT specialists within the Veterans Administration and have been integral at bringing innovations such as 3D printing, virtual reality, and augmented reality into the nation's largest healthcare provider. And so they're going to tell you about that as well. I'm going to hand it over to Justin first. The way that we're going to do this is we're going to have a 10-minute talk, followed by up to 5 minutes of questions and answers from each of the speakers. And then at the end, we can round robin if you have additional questions after hearing all 3 mini talks. So thank you again for joining us. We're very excited to learn a lot from our speakers.
All right. Hopefully my screen is shared now, but thank you for the opportunity. Thank you for SIG leadership to allow me to present. Name is Justin Ryan, research scientist at Rady Children's Hospital. And I'll be talking about enabling accessible 3D for clinicians. This will really set the foundation for some of the latter talks regarding augmented and mixed reality. I don't have any financial disclosures. And as a bit of background for me, again, I'm at Rady Children's Hospital, San Diego. We're a freestanding nonprofit organization, 444 beds. We recently just merged with Children's Hospital of Orange County, which they have 387 beds. So we're starting to grow in size. And I think some of the challenges that I'll talk about in enabling accessible 3D will have more nuances following this merger. Specific to the lab, Helen Will Webster Foundation 3D Innovations Lab, we established in 2018 to bring 3D printing and 3D visualization to patient care. This built on 8 years of experience of myself at Phoenix Children's Hospital, where I had a 3D printing lab focused on cardiac anatomy. Part of that was as a graduate student, part was as a team member there as an employee. I have 6 staff members within my departments, but really 4 dedicated for the 3D innovation lab space. And we produce hundreds of anatomical models per year. And that spans surgical planning, cardiac surgery, intervention, orthopedics, neurosurgery, ENT, kind of whatever department here utilizes medical images for surgical interventional planning, we largely support them. Our lab itself, we have 8 different 3D printers spanning several different types of technologies. We have some VR headsets. We even have a VR testing room. To date, we've produced over 2,600 models since we established. And models here, the specific nomenclature does not necessarily imply 3D printing, but it implies an end-use application. So that could be a dedicated 3D on a computer screen. It could be a dedicated 3D in a VR space, or it could be a specific physical model that you're held in your hand. Now, we have grown rapidly since 2018, but really that rapid growth creates an impediment to enabling accessibility, and that became a very considerate focus over the past 2 years for our lab. So learning objectives for this webinar, I'd love you to walk away understanding how one organization had challenges to making 3D data accessible to clinicians. Now, our approach might not be scalable for your organization, but it is something to keep in mind. We'll do a review of the current state of 3D data archiving when it comes to hospital systems. And then I hope that through this, you also learn how to seek inspiration from unique resources. Specific to our environment, we really tapped into video game development principles. To set the stage further, I think it would be good to talk about an archetypal case that we often see in our organization that necessitates these advanced visualizations, and that's double outlet right ventricle. So let's imagine a scenario where a patient with double outlet right ventricle or door of anatomy has a surgery scheduled in about 2 weeks. A CT scan is performed. A surgeon reviews a CT scan. They see the PACS-based 3D reconstruction in terms of spins and tumbles. And based off that, they're confident that a 2-ventricle repair is feasible. And if you're not familiar, this is a process where they place a baffle inside the intracardiac anatomy in a specific shape, very 3-dimensional to bring blood to where it needs to go. Given how complex the shapes are, often they request 3D prints. So we create a 3D print. So this would be an example of a spin or a tumble that you would see in PACS. We might go through the reconstruction process. So this is different than the PACS-based reconstruction process. We reconstruct the anatomy, reconstruct the intracardiac features. We do some Boolean operations. So now our anatomy is hollow. So all these different steps to create a 3D printed model. Now I'm oversimplifying here just because it's not within the scope, but all this is very achievable by organizations that have the appropriate software and training. Then we go to the 3D printing phase. As mentioned, we have 8 different printers. Some print in color, rigid media. We have ones that print in flexible media. So we have these different opportunities available to us. And we produce them. We provide them surgeons. They might cut or operate on the models. They might just review them for morphologic analysis before operating. But here is what happens very common to our organization. Right before the surgery, the surgeon reaches out and they want to review the 3D data, even though we've produced numerous prints, and they require that an engineer drives the segmentation software because it is pretty, has a steep user interface that a surgeon typically isn't going to understand. So the challenge is what's in the surgeon's head might not match what the engineer requests. So we can imagine a scenario where a 3D reconstruction is present and a surgeon says, rotate the model right. We have to understand, is that right out of plane? Is that right in plane? Is it some other orientation that they're not conveying? And that's a challenge. It creates an impediment to what the surgeons are thinking. And we want them to act and think at the speed of thought and not be encumbered by technology or this nomenclature difference. So the challenge here is to really make 3D as accessible as cross-sectional images are to them. And a group of us engineers back in 2016 recognized this challenge. We worked with Society of Manufacturing Engineers to in turn work with DICOM, the organization behind the DICOM file standard, to reopen Working Group 17 so that we can enable encapsulation of this 3D data that we all use, STL, OBJs, to be part of the DICOM payload. And that was accepted. So in 2018, encapsulation of STLs was updated as part of the specification. In 2020, that also extended to OBJ and its texture maps MTL. So hypothetically, as far as 2020 goes, we can store this data inside our packs. But we saw a resistance to that. We have not seen largely the software companies update their programs to enable encapsulation. So our lab itself tried to create a tool. This is called Media to DICOM, and it can be downloaded right now, where a user can take an STL or an OBJ and put it inside a DICOM wrapped by source images. So hypothetically, we can achieve that. So you can push your software vendors to also support the STL and OBJ encapsulation. It's quite feasible. But even if we achieved archiving, that's not the full story for accessibility. And if we look to the greater commercial world, video game technologies have really addressed this accessibility quite well. A video game user is interacting with really complex three-dimensional information on a screen. They're asked to do complex tasks, but by and large, they try to design the user interface, user experience to be very accessible. They want as many video gamers as possible to use a specific game. So we try to leverage those principles in building a tool for our surgeons and interventionists, a viewing tool. So this tool, we call it ArcViewer, and it is a 3D viewing software built off the Unity engine, so pretty common for video games like Pokemon Go and Among Us. Those were developed on Unity. We connected it to our database that we have for 3D models, and we have an API. So we developed a viewing tool that allows our clinicians to query specific 3D reconstructions that have already been created, bring them into a 3D environment, and try to be as accessible as possible. We ran pilots with our surgeons and asked them to do very simple tasks like rotating and hiding and showing structures, doing transparencies, and even more complex tasks like clipping planes. And we revised our process based off this really video game type pedagogy. And we created this tool. We worked with InfoSec to get it released internally. And so now we see great adoption from this technology. We've seen our 3D reconstructions really explode over the past 2 years since this tool became available. We recognize that this tool could be used by the community, so we released a version for the public to download at no cost. So they can go in there and download download the software, open up STLs or OBJs, 3MF files, kind of most of the standard ones in the software and be able to visualize. We did strip away some tools that might accidentally convey diagnostic use, such as measurements, but this tool is freely available. Now, the tool that we built isn't necessarily unique. 3D viewing software is out there and accessible. 3D Slicer is present, but it has a steep user interface that we're not typically seeing the average surgeon interventional use. Mimics Viewer is a tool really designed specifically for this purpose, but for our internal use, it requires cloud access, which wasn't really permitted at that point in time. Plus, we wanted the tools to fit our environment, so that's why we approached viewing that way. Now we put all these tools in place, again, in order to help our surgeons not be encumbered by technology, but be able to interface with 3D data that has already been developed in order to optimize our surgeries. And so we hope to spread this information to other organizations so they can better leverage the 3D data that they've already created in process for 3D reconstructions, for 3D printing, for virtual and extended reality. These data sets should really be in the hands of surgeons when they need it. This is very much a group effort, and in particular, while I'm very proud to talk from our lab's perspective, much of this work product is from our innovation engineer, Param Gulami. He has a background in video game development, and that really enabled us to develop these bespoke tools for our hospital use, but then as you saw, for the greater community. So takeaways from this talk. I think by and large, you're here because you're already embracing new technologies, new mechanisms of visualization, but really focus on making sure that your entire audience has access to this 3D data. It shouldn't really be gatekept by someone who has the experience and expertise of advanced 3D software. And then also a bit of a call to action. Those STL and OBJ encapsulation for your PACS or VNA, those are part of the specification, have been part of the specification for about 5 years now. You as a customer really have a lot of power, especially during RFPs, to make sure that your PACS or VNA can support these specifications. So during these times, reach out to your vendor, say that this is what you want, and they'll start to work on tools for that. On that, I want to thank you all for your time in this mini presentation. Here are some QR codes for our free viewer. If you don't already do 3D reconstruction, the NIH has some 3D resources so you can play around with 3D files. Thank you again.
Fantastic. Thank you, Justin. Any questions from the audience? Please type them into the Q&A. Justin, quick question. How simple or difficult is it to be able to get your ARC viewer on a hospital network? Is there a lot of challenges, do you think, or have you heard from other people that have imported it to other hospital systems?
So with the caveat that's not for diagnostic use, we don't require any cloud access, no internet access. There's one element that kind of pings a server to see if it's the most recent version, but you can totally firewall this. So you're welcome to install it and completely firewall it. It'll work just fine. You can use it to open up 3D files. I think what is challenging in the light version, in our own version, is it's not DICOM QR yet. So that's what we're working towards next, is we want to be able to store the 3D data inside your PACS or VNA, your enterprise archive, wherever it might be, but then use DICOM protocols to query and retrieve. The solution we have internally is very bespoke to the database we built and isn't necessarily scalable to other organizations. But that's a challenge I think a lot of us face, is how do we make sure that a surgeon at 11 p.m. at nighttime who wants to review for a case tomorrow isn't having to go through hurdles in order to look at that data. That's ultimately our aim.
Another question for you. Have you found that surgeons favor one way of looking at the data over another? Like if they were given 3D models, the ability to put on a headset and look at it versus looking at it on the screen, is there a preference, and do you know why?
I think it depends on the end use application. Our neurosurgeons here, I would say, really embrace mixed reality. I think that's just kind of their perspective when they're in the operating room. A lot of their procedures are kind of keyhole-like, so they're kind of limited to that field of view that's a little bit atypical. Our cardiac surgeons have strongly preferred 3D prints or the ARC viewer, our kind of 3D model viewer. And we're starting to see a little bit of plateauing on our 3D prints while our requests for 3D reconstructions have gone up, which implies that they are much more embracing the 3D viewer. And I wouldn't necessarily say it's generational, but I would say it's a bit more departmental from what we've seen here at our organization.
Fantastic. If the audience has other questions, go ahead and type them in. We will come around at the end for a round robin.